5, 4, 3.
Well, welcome back to the International Social Prescribing Conference, day 2. We had a riveting first day, and I thought I might just point out some of the highlights to those that weren't able to catch up with everything that went on. We started off with Sir Michael Marmot, quite an emotional presentation for social scientists, I thought. He told us how life expectancy is actually levelling off, and particularly for those least well off. He told us how COVID had exposed and amplified those terrible inequalities that he described, and how the least off, and this is an extraordinary statistic, he said the least well off would have to spend 75% of their income on food if they were to eat healthily. That is an extraordinary statistic, isn't it? Then finally he said, as a great rallying cry to those of us in social prescription, that he felt that social prescription was a major way of addressing these inequalities. He clearly said that we needed to look at them on high, politically at the centre, but that social prescription, he thought, was a really major way of addressing some of the awful inequalities that he mentioned. Then afterwards, we had Anant Jani, who somewhat reassuringly told us that in the UK, at least, referrals to social prescription were mostly coming from deprived areas. That's to say, deprived areas had higher rates of referral. However, conversely, the level of uptake from those referrals was sadly lower. The use of social prescription, he told us, was less for ethnic minorities and also particularly for children. And then he told us about the minimum data set they're using, but did give, I think, a very important warning, and that was to say that we also needed much more data from the actual, from those actually doing it in various areas to give us that granularity that we need when we're trying to think of what we are going to do to improve social prescription where it is. And then we had this extraordinary presentation by Ian Dodge, who is in charge of social prescribing at NHS England, right at the top. And he said, for the record, that social prescription is now irreversible, he said, partly because we now have a political consensus throughout all the parties here in the UK. He thought the imperatives now were to make social prescription comprehensive, universal and consistent, that we needed to create the evidence base that was going to persuade commissioners to make sure that it did increase and develop as necessary. And we also needed to learn more about how it could be done best. What sort of sizes of lists should each social prescribing link worker have, and what models work best? Then we had David Sweeney, who reminded us that social prescription community is different. We support, we share, we drop the ego thing and look after each other, and that's very much what I think we've been seeing in the conference so far. Maren Simpson reminded us that the end point of social prescription is about creating healthy communities, because that's the only way we're going to stop people falling in the first place and enable our health system to be sustainable. And we're going to need resources to do that, to create the infrastructure for those healthy communities. And then Darren Halifax sort of built upon that with his yin yang of the link worker and the offer. And do you remember the travel agent analogy, that we mustn't end up with lots of travel agents, social prescribing link workers, but without anywhere for them to go? And the importance of building up the voluntary sector. And I think he was a shining example, really, of how we are going to manage this hiatus over the next 2 or 3 months as commissioning groups move to integrated care systems, and how we actually embed social prescription in the new integrated care systems. And his recipe, and I have to say he does it in spades because I know him well, it's all about relationships and communication. And that's exactly what he does. And that's why in Devon they are taking things forward and making sure that there's all the horizontal and vertical connections that are needed for social prescription to thrive. And then finally in the discussion, Sam raised this whole issue of how we overcome variability in dashboards. And this old chestnut, which we're all going to have to face in social prescription, of how do we standardize it without homogenizing it. Then finally, we had the Social Prescription Awards, as inspiring as ever. We had Callum, the Link Worker of the Year, Ben, the most inspirational person, and those three wonderful students, David, Rania, and Wentin. And I just thought they were slightly different from the awards that you tend to see. You know how you get these pompous people coming on stage and saying they're humbled, and you know how you get these, these actresses and actors coming on stage and saying it's all due to them, when actually they mean it's all due to themselves. Well, there was none of that. There was this wonderful collegiate sharing, partnership, supportive bit to it, where everyone was winners, and I think that they expressed the best of social prescription. So that's yesterday. Today is today, and so I'm going to hand over to Marie now to give us just a bit of a glimpse as to what we can expect today. Marie.
Thanks very much, Michael. I'm so glad you did that roundup. A brilliant roundup. I don't think I could do that. My brain was spinning last night after everything that happened yesterday, and I swear I haven't slept properly because I'm still processing the amount of content. And of course, Social Prescribing Day hashtag trended on Twitter, so you've come good again, everybody. Thank you. And you're trending on Twitter there. So today we've got a real international feel and we've got a real workforce feel. So this morning we're going to be having a real trip around the world, because the development of social prescribing in different countries is really coming on, and you're going to hear about that. We're then going to be looking at workforce development. So the other thing that's really important from a system perspective is, how do we support you link workers? How do we make sure you're respected and valued? How do we make sure you've got good competencies, good job descriptions and good clinical supervision, and the priorities for your career development, because this is a new workforce and this work is now happening at pace. So we'll be hearing about that. Then going from system to local, we're having a real deep dive for half an hour into the East of England. So we're going to be looking at how the East of England as a region has been developing social prescribing. Once we've done that, we will have had a break. Hopefully you'll pop into the networking lounge. It's great fun to drop into a table and see who's there, meet new people, meet old friends, keep the discussions going. We'll have lunch, and then after lunch it's breakout rooms time. So you get to choose, do you want to hear something about green prescribing, arts and culture and social prescribing? Would you like to hear about systematic reviews and the evaluations and the methodologies? Or maybe you want to hear about the evidence collaborative and the evidence summaries that were launched yesterday and how those are being translated into products for everybody in social prescribing. Maybe you want to hear about children and young people, and maybe you want to hear about more developments around the world, because there's some great stuff going on. And I'm just thinking, we've got a whole session on student clinical champions and student champions from the allied health professionals. So there's just so much to actually take part in. It's all recorded, so the ones you don't get to, you'll be able to pick up later. We're going to finish the day hearing from you. So we've got 3 questions we're going to poll you on. So that will be a quick interactive bit on your phone, and we'll hear your highlights, your concerns and your opportunities that you see moving forwards. And that will bring us to the end. Before I hand back to Michael and Sean to take us into the next session, I would like to introduce you to our poet in residence, Harula Ladd. Now, for the last year and this year, Harula has been coming to the conference, listening to everything you say, and then writing these amazing poems. And in fact, I looked at last year's poems last week, and I could still remember the sessions when I read the poem and thought, oh, I remember that was when Sam talked about this, or somebody talked about that. And I think it's a great way to try and distill the essence of what we have been talking about. So Harula, I'm going to hand over to you to share a couple of your poems, and I'm looking forward to hearing you speak your poems and not me this time. So welcome and thank you.
Great, thank you very much for that, Marie. It's an incredible opportunity to be here as an observer and trying to process and digest all of this incredibly inspirational sharing that's been happening. The poems that I've been writing are also all on Twitter, but I'm going to share a couple of them here for you now. This first one is called On Partnership, Not Pills. Certain stories knock on the door of your heart. If we invite hope to cross the welcome mat, we discover so much more by listening to the surrounding circumstances, not just the symptoms, of someone complaining of lack of sleep. Ask the why, not just the what, and you'll find the front door of their home won't shut. It needs mending. That is what needs addressing. Once the door is secure and looks good as new, the anxiety at the root of the lack of sleep is a banished bad dream, and not a pill to be seen. Paint and hinges can be tools for well-being too. So that's that one. Yeah, just this reminder that there are so many different ways of supporting people if we listen and pay greater attention to their surrounding circumstances, not just the symptoms they're presenting with. And throughout the day, there was a huge emphasis on relationship and the importance of building those connections and partnerships. So this is called Relationship. It's all about relationship. But not everyone gets it, accepts it, because relationship's not a quick fix. A social determinants approach to health isn't satisfied by a 10-minute visit to the GP. It requires transforming our whole society. A compassion revolution demands strong relationships, but trust takes time to establish, and conversations must be allowed to ripen. You've got to pick your moments for the big dig, the verbal excavation of what's beneath the painful situation. Then comes community engagement. We rebuild the foundations on solid connections that may have taken time to create, but now they're unshakable. All of life can feel it. Lean into it until fresh hope blooms. Thank you.
Thank you, Harula. Oh, that's so fantastic. We're all clapping here in the presentation room, and I hope everybody at home has just enjoyed. What a centering way to start a day. And I can tell you that that was Sarah McLaughlin from Northern Ireland who was the inspiration for that first poem. I know that that was instantly recognise and remember that talk. So we're going to send that to Sarah as well, and they can use it at AgeWell. I think that will be great. Thank you very much. So you're going to help us close the conference as well, aren't you, Harula? So we're going to hear poetry from you, and we'll be hearing a personal experience from Joji in conversation with Debs later as well, just to bring us, after all of our discussions today, back to what is the essence of social prescribing, and it's supporting people when they need that support the most. So, Michael, I'm handing back to you, and I'm going to sit back and enjoy this session now. Michael, you're on mute. Has to happen at some point.
First time this conference. Harula, thank you so much. I mean, I take away 3 words from what you said, which is trust, it's transformation, but above all, it's hope. And you know, what wonderful poems. Now we're going to the truly international part of this conference, and we're going outside the UK. And our presentation today is from a very old friend who's been at all our conferences since the very beginning at Westminster Hall. And the presentation you're going to hear was from the organisation that won last year's award. And we're really very privileged to have Lee Kheng Hock of SingHealth today, who's going to talk about the truly inspirational things they've been doing and developing over the last few years. So without more ado, over to you, Lee.
Thank you, Michael, for the very generous introduction. I will just share my slides and then we can get started. Okay, this is the part that's always tricky. Are you able to see my slides?
Not yet, no.
Not yet. Okay, sorry about that. So this will work.
Yeah, they're there now.
Okay, that's good. Okay, so yeah, so I will just start by giving you some theories that we have been following as we do the social prescribing project in Singapore, and then I will give you the context of how we are practicing it and the place we are practicing it, and then to share some of the lessons that we have learned through our journey. So I think we hear all the time about this theory practice gap. So we are constantly asked, where is the evidence that supports social prescribing? And this is what we hear this from academics and advocates of evidence-based practice. Now, on the other hand, we hear the common retort from passionate practitioners who ask, why is there a need for us to do studies to prove things that are so obvious? Now, surely it is so obvious to everyone that alleviating loneliness and improving social determinants of health will bring benefits. So why do we need to go through all the trouble? And I think the truth is in both sides of the argument. Many times the obvious had been proven to be untrue. Now, on the other hand, most things, especially innovative ones, have to start with little or no evidence before they become cornerstones of evidence-based practice. So I think social prescribing is one of such things, and evidence will grow over the years. So for that to happen, we must study the context of all the programs that we are running and implement social prescribing in a very systematic way, collecting data all through, and then to evaluate our programs objectively. So practice-based evidence requires effective practitioners applying good theory, gathering evidence in the real world at the same time, and the practice itself will give us the evidence, just as evidence will guide our practice. We need to contextualize our programs and be very explicit in describing the way we contextualize it, the way we implement it, so that we can understand what works, for whom it works, under what circumstances, and why. So I think Thomas Edison once said that vision without execution is hallucination. So you see pictures of two versions of fish and chips, which will technically meet the definition of fish and chips. The customer reported experience or outcome measure will certainly be different. So a randomized control study using these two different renditions of the dish will come to totally different conclusions of the gastronomical significance of fish and chips. So similarly, studies of complex interventions, when it's carried out without understanding the context, the implementation, will have little value. As we all well know, social prescribing programs are not the same throughout. In fact, diversity in contextualizing to the needs of the person and the community is the hallmark of a good social prescribing program. So we need to understand the adaptation of the recipe, the ingredients used, the preparation, and the cooking, because all this makes a difference and help us to understand how to do a good program. Another theory that we learned to use is this theory of implementation science. And there is this theory of a formula of a successful implementation. So if you look at this simple equation, there are three variables to the outcome which we want to achieve, which is a socially significant outcome. Now, the first element is, of course, effective intervention, which ideally should be evidence-based. But when evidence is not yet available, then it should be based on the sound theory. A good theory such as social prescribing is one that is consistent with empirical observations, is easy to understand and simple enough, explain things broadly, and is testable, and it promotes the development of other theories. And for a theory to become an intervention, it has to be teachable, learnable, and practicable. Now, if we look at this equation, and if 1 is perfection and 0 is total failure, then we realize that they all have a multiplication relationship. Now, if any one of these elements or variables is 0, then the whole project would fail. So it's very important for us to understand and to work on these three respective variables to achieve good outcome. The other thing we learn about social prescribing or implementation of any meaningful program is that it takes time for it to be developed and to become well executed. So there is no such thing as plug and play. So the resources, the work processes, the profit criteria, like for example, like a fast food chain, are very well understood, and they're very simple relative to social prescribing. So it can be easily replicated and standardized across different geography. Social prescribing, however, is a complex intervention, and it's a relatively new innovation in improving healthcare. So it is not realistic to expect that we can just go out, employ a number of link workers by X date, implement a social prescribing program within a few months, and then sit back and relax and expect to collect evidence of good outcome. So studies of successful implementation inform us that good programs take time, and it starts off usually with an exploratory phase where we have to carry out needs assessment, understand the drivers of successful implementation, and then adapt it so that it can work in a particular context or setting. This is followed by installation, where we get all the resources needed, like funding, facilities, very practical things, manpower, and then the organization needs to be prepared before we can launch the program. And even then, after successful installation, we are only beginning to have an initial implementation. It's like powering up an engine once it has been assembled. And then what follows is a series of adjustments and fine-tuning until the initial implementation phase is stable. And until then we are ready for full implementation. And when that happens, we shift our focus to ensuring the fidelity of processes and the quality of outcome. And all this, if you are lucky, takes between 2 to 4 years. So I would now like to tell you a little bit about the context, because if you want to understand how we have failed or succeeded, then you have to understand our context, and then there you can abstract the lessons you need to learn from us. So Singapore is a city-state, it's a country, and it's a city itself. It's a very small city-state. We are about 729 square kilometers at low tide, I think. And London itself is already 2.2 times bigger than us. And we are very dense. Our population density is 8,358 per square kilometers. So you can see that we are packing people up vertically just to occupy that square kilometers. But thankfully, we are a relatively affluent society. Our per capita GDP is 9th in the world. We have the highest number of millionaires in the world. 1 out of every 6 Singaporeans you meet will have assets of over more than $1 million US. Unfortunately, all this comes with the downside of being the 3rd most expensive city to live in, and the pace of life is really fast. We hold the world record of having the fastest pedestrians in the world. Everybody is dashing around at a very high average walking speed. So this is the context of the community that we live in as a city. Now, the other thing about us is that we are highly efficient. As a very efficient city-state, we also have a very efficient healthcare system, which is ranked to be the most efficient in the world, even before and during the pandemic itself. Now, despite all these favorable conditions, we are deeply worried about the future of our healthcare system, because we have one of the fastest aging population in the world. And this aging population comes with the prevalence of frailty, multiple chronic diseases, which results in an increasing demand for healthcare services. So to sustain our current healthcare system in a very efficient state into the future, we will need a dramatic increase in healthcare workers at a time when our workforce is shrinking, brought on by the same aging population drivers. So in Singapore, we are searching for big ideas and new models of care, and we think social prescribing is an idea that will work and guide us to remodel our healthcare system. So now I will go down to where I work, which is where we introduce social prescribing in Singapore. So I work in a healthcare cluster called SingHealth. It's one of the 3 clusters serving our entire country. It is Singapore's largest group of healthcare institutions. It consists of 4 acute or tertiary hospitals, 5 national specialist centers, and a network of primary care clinics. And most important and interesting of all is we have 3 community hospitals which are responsible for ensuring continuity of care. And this is where I work in. Now, I think we will need to explain to you a little bit about community hospitals and how it works, because I think it's hard to imagine, because it's quite unlike what you may find in other countries. So community hospitals are unique innovation of a healthcare system. They are developed to meet the changing healthcare needs of an aging population. So you can understand that for older patients, being fit enough to be discharged from an acute hospital often means that doesn't mean that they're ready to go back to regular life. And the typical profile of our patients are, they tend to have less optimum social determinants of health. They are more likely to come from the lower socioeconomic group, and they're more likely to be socially isolated, have multiple chronic diseases that are not optimally managed, and then they need lots of social care services. So we find that in our healthcare system, there is a natural triaging system almost that direct all these patients who really need social prescribing to our community hospital. And for this reason, we have decided to implement our social prescribing in the community hospital. Another factor that favors social prescribing in community hospital is our philosophy of care. We are very community oriented. In fact, we are called community hospitals. The vision of a hospital is to bridge care and build communities. And we strive to provide a home-like environment, and we like to bring the community into our hospital. So besides treatment and therapy sessions, we try to fill the rest of the days with activities that will encourage patients to stay active and socially engaged. So learning all this, we realized that we will want to follow the implementation science approach, and we realized that it actually falls and merge into the PDSA cycle used for continuous improvement, quality improvement that people are familiar with. So when we use that to explain how we're going to implement social prescribing, it was very easy for us to get our colleagues onto the same page. So then we launched into this. So back in 2009, our journey really started. We started with the exploratory phase. We formed a project team, which included senior management and clinician leaders. And then we came to this very conference in 2009 at the second International Social Prescribing Conference. We met many encouraging colleagues and learned from many social prescribing projects. And we met very nice thought leaders like Michael Dixon, Marie Polly, and James Sanderson. So we also, these people in turn link us up to many more advocates in the Global Social Prescribing Alliance. So when we returned to Singapore, we were bouncing off the wall, full of energy, and really convinced that social prescribing is the correct theory to follow for our model of care. We started to engage government agencies and internal stakeholders in SingHealth. More importantly, we shared what we have learned with our staff, especially all the clinicians in the hospital. So the next phase is the installation phase. We continue to spread the ideas, adapt the ideas to meet our needs. And we were successful to convince our funders to give us a budget to start our project. And with that, we started assembling the manpower, create a rudimentary training program, found toolkits that are useful, and then that are useful to help the practitioners assess patients and develop a social care plan. And then we put in framework to collect data, and off we go. In May 2020, we successfully installed social prescribing in Bright Vision Hospital, which is one of the 3 community hospitals under our group. Unfortunately, as we were warming up in the initial implementation phase, COVID-19 hit us with full force. So as part of the response to the crisis, Bright Vision Hospital was converted into a community hospital. And then we had to stop our program due to the crisis. We have to move all our resources to support the fight against COVID-19. But we have a reduced team still working on the project, and to keep the program running at a smaller scale so that we do not snuff out the flame. And we took the opportunity to work on improving our processes and training systems. So while we wait for the pandemic to be over, it seems to just drag on and on, as we all well know. And we decided that we must keep our program going, notwithstanding the difficulties. So in 2020 October, we moved the installation from Bright Vision Hospital to Sengkang Community Hospital, which is the second hospital in our group. So of course, we have to take one step back to installation and we start all again. So presently, we are moving along the implementation phase. We are now trying to ensure fidelity and then to ensure good outcomes. So despite the unexpected Omicron surge in cases, we are still continuing the journey. So just 3 weeks ago, we have installed social prescribing in our third hospital, which is Outram Community Hospital. We were pleasantly surprised that the clinicians were quite upbeat, although they are really battle weary and really almost at breaking point, with this incessant increase of numbers of COVID patients. But I think this is when it dawned upon us that this deliberate effort that we took really paid off, because the clinical team were prepared and ready. In fact, many of them told us that they were looking forward to having implementation having the implementation of social prescribing in their hospital. So for the future, we decide, remember the 3 variables. I think we have to continue to work on the enabling context. And this we take a leaf off from the universal personalized care proposal of the NHS long-term plan. We believe there are elements there that will help to build this enabling context. So as part of this, we have invested some resources to create a training program. So we realized we need to build a very highly skilled non-clinical workforce who are highly competent practitioners of social prescribing. And these people need to work closely with the clinical team and provide patient-centered social prescribing plans. So in Singapore, we have a national training system known as WSQ, or Workforce Skills Qualification. I believe this is similar to TVET, or Technical Vocational Education Training System, which is advocated around the world, including the UK. And we have identified 4 core competencies group, and we have developed a modular stackable curriculum based on this. So in fact, we have already started training our first batch using this new curriculum. We have received very good feedback from the learners, and we find that this course is attracting people with the right traits, people with the relevant life experience who are looking for meaningful work that will contribute to the community. So we are very confident that we are on the right track, and we'll be able to develop a good non-clinical workforce to help us in our work. So the pandemic also told us that we need to be highly responsive to the community needs. So when COVID-19 came, we realized that there's a new social determinant of health called digital exclusion. Our elderly patients were bewildered by the slew of social distancing measures, fearful of leaving their homes, and when they venture out to get essential supplies, they are challenged by unfamiliar barriers such as contact tracing, apps, QR code scans, and entry barriers. So many of them do not even own a smartphone. So we responded by quickly creating an e-social prescribing program that teach the elderly how to stay engaged with the community and to navigate all the barriers using their smartphone. Another enabling context is we need to have links in the community. And linking to community assets is a key component. To enable this context, we have embarked on developing a methodology of asset mapping, following the theory of asset-based community development. We believe that we need to have a living asset map that is reflective of what is really going on in the community. And essentially, there will be 3 layers, and we intend to develop this using digital maps, community walks, street audits, photo voice, and case management to add life to our asset map. So, another important component of building an enabling context is the advocacy or concept of social prescribing. So our strategy is to work with local and global partners. So at the recent scientific congress at SingHealth, we organized a social prescribing track and brought in international speakers to inspire our local clinicians and academics. We have introduced the idea of social prescribing to our students, medical students, and they have spontaneously formed a students' special interest group, and we have connected them to the International Student Movement for Social Prescribing. And through our partners, we are helping to support the development and spread of the idea of social prescribing. So we are very privileged to be invited to contribute to WHO Western Pacific Regional Office, or WIPRO's, initiatives to spread social prescribing. And in fact, this month, WHO WIPRO has just published a toolkit to support the implementation of social prescribing in our region. We are also happy to report that colleagues in Cambodia, supported by WHO WIPRO, have started a social prescribing pilot And next month, WHO will launch a free 5-hour e-learning program in social prescribing using the Open WHO training platform. So social prescribing is slowly becoming a world movement that is set to improve the health and well-being of people around the world. So in conclusion, I would like to say that all indications tells us that social prescribing works, and evidence will build up over the years. So we should stay the course, study our programs closely, build up the evidence base, and in the meantime, adapt social prescribing to meet the needs of our communities and our healthcare system. So thank you very much for allowing us to share what we have begun to do in social prescribing. And none of this would have been possible without the inspiration and generous sharing of our international colleagues around the world. So we started our journey here in social prescribing in 2019 at the second conference. So our wish is that we can continue to learn from one another, and more countries will join our community of practice and implement social prescribing. Thank you very much.
Well, thank you, Lee. I mean, that was a most extraordinary, thought-provoking and interesting presentation, and showing your amazing leadership and your amazing energy in adapting and improving all the time. And I love the idea of this whole idea of the bringing the community into the hospital. That's the missing link in primary care and hospitals throughout the world. We need to connect the two so that they're joined at the hip. And I think what I'm seeing is in SingHealth an organisation that is really ahead of the game, this whole issue of how we treat our ageing populations worldwide. So I think you're a shining example for everyone, and thank you so much for that presentation. And I have to say, I have to take away this image of everyone in Singapore walking faster than everyone else in the world. You know, it's a wonderful thing in my brain. Now I'm going to hang over to Sian, who's been seeing the questions coming in. Sian, who is our chief representative from Australia. Sian, over to you.
Hi, and hello everyone. So good morning, good afternoon, good evening, and very good morning for the folks who are dialing in from the US and Canada. I'm delighted to be here, and thank you for inviting me to join. What a great presentation. I just was having a quick look, so thank you for that. I was particularly interested myself. We had a conversation today about asset maps. So I was really interested in the ABCD, but also the way that you've put together this living asset map. And I suppose one of my questions, and I will go to, there's a question from Joe or a comment from Joe in the chat, but how do you bring that asset map together to make sure that it's always current? You know, I saw on the slide that you got participatory approach, but could you give us a bit more information on that?
Yeah, so we realized that the asset map is out of date the moment you put things inside. So what we believe is we take the approach of crowdsourcing. People are free to contribute to this map. And what we do is we will first, of course, contact all the people that is available that we can reach out through the internet. Then secondly, we have this advantage because every patient that we bring out into the community is an opportunity to find new links. So for each case that we bring in, we will say, okay, this person stays in this particular block of apartments. What does the map tell us that they have? And then we will go and walk the ground, and you will realize that every time when you walk on the ground, you'll find different things that are not on the map. And you will also find that activities are all sprouting all over the place that is not published in the internet as well. So so it's a system of a sort of a bottom-up approach to find information and to place it and to share it among our well-being coordinators or link workers. So it's, I think, a job that's never done, just like Google Map is constantly updating itself by sending the cars roaming the streets, right? So in our case, our link workers will have to do this job for us, and it's not an easy task.
No, thank you very much indeed for that. I agree, it is constantly dynamic. But I also think what you've also said, your comment about enabling context, it's a great way of bringing in that context and keeping that context live. So Joe, thanks for your comment about the timeline, that it's really useful to have the timeline for development. And I agree, because I think it manages our expectations for all of us as we're developing these programs about you know, how to do them properly and how to sort of phase them. I'm going to have to put my glasses on for the next one, 2 secs. Great to hear how implementation science is being used to spread and scale social prescribing. Completely agree. And then the same comment as Michael said about community hospitals, and great connection in with OTs. And then last question that I will ask, if I may, before Bogdan, we look at the international series. I'd be interested to hear about how the voluntary sector, civil society, varies around the world, and how this affects social prescribing delivered in different places. Now, Lee, you mentioned around Cambodia, but as you develop these materials for Western Pacific through the WHO, are you seeing differences in terms of sort of the models, and how does that affect the information that you're putting together?
Yeah, so we must be very mindful that whatever we do cannot be transplanted lock, stock and barrel into another country. And sometimes even within the same country, the communities are different. So we must be very respectful of the unique setting and the culture and the language, and their take of social prescribing is different. So I had the privilege of being involved through some discussion with our colleagues in Cambodia. And I think what we do in Singapore is totally not applicable to their country, but I think the principles are the same. You know, social determinants of health, identifying a population in need, developing components, and then all this, you know, the installation, the gathering of resources, the initial implementation. These are all very good principles that you can follow. So, for example, I was very fascinated by their take on social prescribing. So, what they intend to do, as far as I can, if I know, is that they intend to implement social prescribing in rural villages. So, they have identified mental health of some of these people as people who will benefit from social prescribing. So they have migrant workers who have returned to the villages, and because they have been away for such a long time, they are disconnected from their communities, and they are under a lot of stress. So, and their take is that they don't have to recruit link workers from scratch. What they have community health workers in the villages, and they are thinking of using the materials and toolkit developed by Wipro to train them with this additional skill to do social prescribing. So when I heard that, I thought, oh, that's really brilliant. You know, that's how you have to do. You always have to adapt to the context and use whatever you have in the community in terms of the assets. So I think they are very likely to be successful as well, perhaps even more successful than us, because they have this deep understanding of what they need to do for their own communities.
Yeah, I completely agree. I'm glad that you mentioned around community health workers. Thank you. I'm mindful of time, so I'm probably got to obey Michael and Bogdan here. Thank you very much indeed for those. Michael, may I hand back to you?
Well, yes, no need to introduce you. Now, on your sheets, you'll see that Jan from the Netherlands was going to be chairing the next session. Unfortunately, technological reasons don't allow him to do so. So our chairs for the next session, looking at the international scene, will be Sian from Australia and Bogdan from the UK, who leads the Global Institute. And between them, very much look forward to hearing what the international scene looks like. Over to you both.
Superb, fantastic. Thank you ever so much, Michael, and such a pleasure to meet everyone. And it's wonderful to be here and during such a special week as well. It's great to see so many of you attending. I'm seeing many of you tweeting, and I'm wondering if your fingers ache, because mine certainly do after yesterday. Marie spoke a bit about how yesterday went, and it was a fascinating lineup of speakers. But also just wanted to wish you a happy belated Social Prescribing Day. Now, as myself and Sian move now into the international picture, what we hope to do is to portray and paint a picture and take you on a bit of a trip around the world, because it's truly transforming to be into a true global movement. We've thoroughly enjoyed Dr. Lee's presentation. I loved particularly the analogy with the fish and chips example, just to say that the UK, actually, we wanted to share we may not have the best fish and chips, and we are aware of that. And we know communities across the world work differently, and we want to learn from each other, share that knowledge, exchange that knowledge, and be able to see what works and what doesn't work on the ground. A great example of that is the secondary care model that Dr. Lee has expressed in bringing communities into the hospital. I think we should be doing that more in the UK, and I know colleagues in Ireland are doing that as well, and through David Robinson as well. But without further ado, Sean and I will now want to find out a bit more about yourselves first and foremost. We have designed a poll to find out where you're tuning in from. We want to see how many countries are involved today. So if you join the polling that will be published shortly and announced on the chat, you can skip the name part, it's anonymous as well, so you don't have to do that. But if you type in the country where you're coming from, and I would say time zone next to it, it would be fantastic. So just put the time next to your country, AM or PM, but it would be wonderful to see that. And I'll give you a second to do that whilst the poll is also getting in action. And I'm suspecting my colleagues will just post that on the chat. And in the meantime, whilst you all do that, is just to say that we in the presenters room, we're having a laugh about this, because there's always some of us that tune in at a random time. And I think you will see Kate later on from Canada, who's going to be tuning in from very late at night. I'm not going to say early morning because it's still night there, but we were having a giggle about the idea of being flexible and joining in at 12 midnight or at 4 a.m. in the morning. I can see we already start having some answers. So thank you for joining the poll. That's much appreciated. Please keep filling that in. And I can also ask the presenters to do the same. It would be brilliant to see some countries. There we go. We can see. There we go. We got people from Australia. We got Singapore in there. We of course got great representation in here. Of course from the UK and much more. Austria, brilliant. Melbourne, Australia, and I can see the time zone in Australia as well. Brilliant. We got US. And I know on our panel, we also have Portugal, we've got Finland today, we've got many others, but just giving you a second. Canada, Yorkshire, brilliant. Well, that is a true region for social prescribing, isn't it, as well? Fantastic. So I can see great representation across the world already. Fabulous, brilliant. Well, you can carry on doing that, but in the meantime, I think we should carry on. And what we wanted to speak today about is really how working with one another has enabled us to develop a true global network. And we all started by helping each other. And that's a bit of a call for action we'll end with by the end of the presentation. We've got a big surprise from one of the presenters, which I'm not going to spoil for you now. You'll have to just hang in there tight and listen to the rest of the presentation with your hearts thinking, what is the surprise going to be about? But it just portrays and shows the efforts in social prescribing across the world. And just to thank international colleagues from across the world who are tuning in into regular meetings. And if you'd like to find out more about this, we'll post a link in the chat later of how you can get involved yourself and join this global revolution in social prescribing across the world. But without further ado now, what I'm going to do is hand over to my colleague Hamad, who will be taking you on a short trip around the world, and he will be starting looking at models of social prescribing across the world. Now, Hamad is a very special person for us. He's devoted his whole master's thesis on social prescribing models across the world. So for anyone interested, do pester in him and get in touch with him, because we're hoping it will be a great piece of work that we all get to admire by the end of the year. Hamad, over to you.
Thank you, Bogdan. I just want to say that it's a true delight and honour to be attending my first International Social Prescribing Network conference, of what I hope to be many in the future. Like Bogdan said, my name's Hamad Khan. I'm doing my Masters in Global Health, and I'll be looking at international models around the world of social prescribing in different health settings. So please do get in touch if you're interested. We'd love to hear from you. Right. Today, I'll be your flight attendant. I'll be taking you around the world in a quick whistle-stop world tour of social prescribing. Here is the world map without social prescribing. perhaps a bit grey, perhaps a bit dull. But with the tireless effort of all of you in the audience today, from the community coordinators, the link workers, the social workers, policy advocates, you have all made social prescribing a truly global social movement. Countries now including social prescribing include Brazil, the US, Canada, the UK, Portugal, Spain, Germany, the Netherlands, Denmark, Sweden, Finland, China, Japan, South Korea, India, Singapore, Australia, and New Zealand. And if you can't see your country on the map yet, then do get in touch, because we definitely want to have your country on the map in the future. So let's start off our tour in the UK, and we're starting the tour in the UK because the UK was the first country of what we hope to be many in the future to actually put social prescribing into national policy with the wider NHS long-term care plan. So for our international colleagues, the NHS long-term care plan is a roadmap for the future of healthcare in the UK, devised across the next 10 years, and social prescribing was a core element of that. And it had a target of having 1,500 link workers, of which we're now very pleased to say that we have achieved far more than that, and we now have, as everyone knows, 2,000 link workers in the UK. But of course, we know that that's not enough, and so we've set a new target for having 4,000 link workers by 2023. Now, this is the well-known link worker model, but we also know that this isn't the be-all, end-all of social prescribing. Social prescribing has been implemented in many different ways in many different settings. So let's have a look around the world about how social prescribing is practiced and what it looks like. So a quick hop over to the Netherlands, where Wellbeing on Prescription, a national knowledge network, has been operating since 2010, so over 10 years now. And it's a partnership of primary care providers, welfare workers, social workers, and policy officials who come together and make sure that municipalities are socially prescribing. And to date, we now have 125 out of 351 municipalities socially prescribing. And I'm pleased to say that last year they reported that actually there has been more prescriptions for health and well-being than antidepressants, which is an incredible feat for the Netherlands to achieve. Again, we're going to quickly hop over to a far warmer climate into India, where social prescribing seems a bit more different, but in the principles it stays the same. We're looking at the ASHA program, the Accredited Social Health Activist program, where link workers are called ASHA workers. And they've been incorporated into the maternal child health program, HIV prevention and interventions, and tuberculosis programs. So you can see how the principles of social prescribing are malleable and adapted into the local health systems and where priority is most needed. Now going over to the islands of Japan, where social prescribing really has been championed in two particular places I wanted to focus on, in hospital of Saitama and the Ishizaka Neurosurgery Hospital, where the link workers called, and I want to get this right, the Saikatsu Shien, they're called the living well-being supporters. They refer patients, and they're from different wards suffering from different diseases, to go to their local voluntary groups, or they actually also have a creative role. So they'll organize events between youth workers, between young children and the elderly patients at the hospital. And you can see some examples here, making sure that there's no isolation that patients usually experience and that they're getting that social prescription that they vitally need, particularly after their treatments. Now we're going down under, and our colleague Sean is going to be talking much more about this, but just a quick overview about the vibrant community of social prescribing, and it's a very community-driven project. And link workers will go by different names, so some would go by community connectors, others would go by well-being coordinators, but again, the much valued work is still the same, and the principle is still the same. And you'll see different organizations, different programs holding things like talk cafes, sewing marathons, whatever it does to take people, to get together, to enjoy time together, especially, after this climate that we've had with isolation. And also there is a vibrant, growing social student community in the social prescribing movement in the US, and Sean is going to be covering this in her section, so I'll let her do that. But just going over now to the US, and the US actually has a widespread adoption of social prescribing. Of course, it has a private-public mix in its healthcare, but it does have a localized wide diversity of models of social prescribing used across the nation. A quick example is the Health Leads organization, and this is it follows the same referral scheme. So a patient is referred by a primary care provider, and then a Health Leads advocate works with the patient and brings them into their local community, bringing out their passions and seeing what voluntary groups they can work on. And of course, we also have the Global Social Prescribing Student Playbook, which was authored by 2 interns at Harvard as well. And it's being used around the world to see how students across the world can incorporate social prescribing in their universities. And that started in the US, and we're hoping for that to span out across the world as well, across universities. So that's that tour of social prescribing around the world, and I'll hand it back to Bogdan.
Fantastic. Thank you ever so much, Hamad, for that brilliant introduction. Can I just double check I am live, as I can't see? Perfect, you can all hear me, that's very good. Hamad described himself as a flight attendant, but I can't resist and just say, I think he's a captain of the ship in terms of social prescribing there, because he's done a superb job. And I'm not sure many of you are aware, but I think it's worth saying that Hamad is going to be a first-year medical student next year. He's a student doing all this work on the side of everything else. So I think if we were in a room, we would have given him a huge round of applause. Certainly a rising star that I hope many of you will get to work with and see. But I'm certainly very proud of what he's achieved to date, and we look forward to working with him further. But without further ado, we're now going to explore each model across the world in more in depth. And we're going to start with the US, where Hamad is kindly going to go through a series of videos from Delia Beck in the US. Hopefully we'll get the presentation synced shortly as well. Bear with us.
So I just want to make sure that you can hear it.
I don't think, can the audience hear it? I don't think the audience can hear the sound. There should be some sound and the narrative behind this as well. Bear with us a second whilst we try and do that. And Hamad, if that's not possible, then we will move on to one of our next colleagues. But let's try and give it one more go. If no sound, then we carry on. I still can't hear anything. So we will jump to Canada because we are good at flying around the world. So I think Canada, you are next in that case. And I do apologize for the technicalities. It's always tough on Zoom, isn't it? But that was the US. We will summarize all the points from the US and we will send the video following up the conference as well. But without further ado, we have a true leader in social prescribing joining us from Canada. And I'm hoping you'll also hear some good news shortly too. So the surprise is coming, not spoiling it, just giving a bit of a spoiler alert. Kate,
thanks, Bogdan and Hamad. Can you hear me? Am I live? Good morning. Bonjour, hello, Annie from Toronto, Canada, where it's just about 5 o'clock in the morning. So only the pets and I are up so far. I am really thrilled to be here and speaking to you from the traditional territory of the Haudenosaunee, the Huron-Wendat, and the Ojibwe people here in Toronto, Canada, now home to many Indigenous people from across Turtle Island and the world. I am here to tell you a little bit about what's been happening across Canada with respect to social prescribing. And I must say how thrilled I am to be here. It's my third conference. And I met many of the other folks on this panel at my first conference 3 years ago, I don't know, a long time ago. And I just wanted to let you know what a welcoming and lovely international community has been created. I always love being here and being part of it. So thank you to all our colleagues around the world. Hamad, if you could go to the next slide. I'll just give a quick context about Canada. We are a very large country with a lot of diversity, many people living in urban areas, especially along that southern border with the United States, but also many people living in rural and remote communities right across the country. Each of the provinces and territories shown here on the map has its own health system. So health is administered at the provincial level, and that can make it pretty difficult to take a national approach to social prescribing because you need to, in some ways, do it one by one, province by province, community by community. But there are many, many examples of social prescribing work starting to crop up right across the country. And there's really growing momentum across Canada for implementing and taking action on equity and social determinants of health, community leadership and well-being, particularly as we start to, with hope, emerge from the COVID-19 pandemic. Next slide, please. So these are just a few examples that I thought I should share. We have the health tapestry and other programs emerging from primary care teams. We've got a wonderful initiative for Parks on Prescription in British Columbia. We have museums on prescription and other arts-based social prescribing in Montreal. We have emerging work happening in regional health authorities across the country, linking multiple parts of our healthcare system from home care to hospitals. And we also have growth in one of the programs that I initially told this conference about a couple of years ago, the Now Links to Wellbeing program, linking community health centers and senior centers for social prescribing. So I'm just very pleased to see this growing momentum and to be part of it and to be really seeing how social prescribing emerging more and more. And in fact, just this week, we saw one of the provinces, Newfoundland and Labrador, has incorporated social prescribing into its 10-year health accord. So social prescribing is now becoming part of provincial health systems and plans, and that's largely due to the initiative of these community-led programs and services happening right across the country. Next slide, please. So here's the big news, and you are the first in the world to hear it. We are today launching the Canadian Institute for Social Prescribing, backboned by the Canadian Red Cross, but including community organizations, including the United Way Centraide Canada and many others, as well as the Canadian Social Prescribing Student Collective, who has representatives here today. So hi students, great to see you here today. Thanks for being here. You'll be able to follow us on Twitter and check us out on our website later in the day, since the day hasn't quite gotten started in Canada yet. We haven't done the launch here, but I wanted you to be the first to know, and I'll be tweeting about it later in the day. We are really excited to join with NASP, the National Academy for Social Prescribing in the UK, and with all of our global partners here at the International Social Prescribing Network to really make this happen at the national scale in Canada and to keep helping our international colleagues to make this into a very robust and energetic and welcoming global movement. Thanks so much.
Wonderful, wonderful, absolutely wonderful. That was truly brilliant, Kate, and congratulations from all of us. I think all of us are clapping at home. We will have to see what the role is. Will it be director Kate Mulligan? Is it founder Kate Mulligan? But we'll work on that behind the scenes, and then we'll see your new signature coming soon. But you have all our support as always, and thank you for being a true leader in Canada, for supporting students, for supporting policymakers, and for establishing CHISP, which is going to be fabulous nevertheless, and support international partners moving forward. But what an announcement, and what refreshing news to just show how the extent of social prescribing across the globe. And I hope many of you will join us in congratulating Kate for the achievement, and do get in touch if you have any questions or if they can be of help. I'm sure we will share some of the work that we do together as well. But we're now moving on to Portugal, and we have Cristiano, who I'm very grateful for, because I'm sure he's very busy in clinical practice. So him being here really means a lot to all of us. And Cristiano has been a true leader in social prescribing in Portugal. It's very interesting to see how he's ignited a true social prescribing movement there himself as a GP. And I'll let you tell you more about Portugal and the model in Portugal as well. Cristiano, over to you.
Thank you, Bogdan, for the invitation. It's a great pleasure to be here between patients and inside my clinical practice. So I would like to start my presentation saying that the Portuguese movement for social prescribing is quite recent and it is a real bottom-up movement, as you'll see. I'm a family doctor in a family health unit. A family health unit is a GP practice, as we call it in Portugal, and also a PhD student for public health, mostly inspired by social prescribing. So next slide, please. The model of social prescribing in Portugal needed to adapt to the Portuguese context. So can you go back to the previous slide, please? Yeah, thank you. So the National Health Service in Portugal, it's a quite new one. It's 43 years old, and it was much inspired by the NHS in England. So we have what is called the ASES, is some kind of CCG, and then you have different primary care services in the community. And apart from family health units that are our GP practices, we have what is called a shared resources unit, where social workers, psychologists, and occupational therapists work. Next slide, please. So considering that we have this kind of resources already based in primary care, it made sense to us to adapt the social prescribing model to our resources. So as in other parts of the world, here the family doctor or the family nurse is the one who identifies the patient with social problems and refers the patient to the link worker. But our link worker is the social worker based in primary care. So the social worker is co-producing with the patient a social prescription and mainly trying to address his non-medical needs, and then connecting the patient with the community sector, the third sector, who delivers to the patient the services or activities in the social prescription. Next slide. So as I told you, it was a local odyssey. So it was me as a GP, a family doctor, who got to know amazing social worker who got very fascinated about the social prescribing movement and start building up the project in our community. You can see in the picture our team, our healthcare team, and probably the reason why social prescribing thrived in Portugal is because the community we serve is very special. So we have a very multicultural community in central Lisbon with 94 nationalities, and that brings a lot of challenges in health provision and where social determinants of health have a big impact in the health outcomes and well-being of our patients. Next slide. So about the way we started, it was essential it was essential to engage with all the partners. So we were reaching health leaders to get their support for the project. Then we were meeting with health professionals to raise awareness about social determinants of health and empowering the family doctors and family nurses to refer patients to social prescribing, and they were part of all of this co-designing of the service. Then it was essential to reach out the third sector and try to recruit partners to make our social prescriptions. And in the previous 4 years, we are working with over 30 partners and providing different activities in our local community. Then it was also essential to work a little bit with the patients on social media and raise awareness using Facebook pages about the social prescribing movement happening in Portugal, so we could inspire our other healthcare teams to do it. Next slide. So actually, social prescribing started as a public presentation in February 2018. Then later on in the year, the first patient was referred to social prescribing in September 2018. Then in the next year, another family health unit join the social prescribing movement and start referring patients. And then we were covering about 30,000 patients. And in same year, we got to be finalists in the Good Practice of Healthcare Prize in Portugal and winning as well the Sustainable Healthcare Prize. And this is, it's very special because it's a real bottom-up project without any kind of financial support. Then on, we got the Mayor of Lisbon to found the research of social prescribing and through a partnership with Nova University. Then we can continue. Then also the Health Parliament Portugal decided to support social prescribing, releasing a document about the next steps, what should be done to raise social prescribing in Portugal. And then we have the visit of different politicians because of social prescribing, the President of the Republic of Portugal, then as well the Director of World Organization of Health in Europe, and it happens that the Parliament of Portugal started to recommend social prescribing to raise in local communities, but then the local mayor changed, the Parliament is changing, and we are somehow in the point where we don't know what will happen. So next slide. I think what the most special thing about social prescribing in Portugal, it was all about the meetings with the community. So every month you are meeting the third sector in the community. We, as a healthcare team and social worker, trying to understand better the community, the resources, mapping assets, and then we needed to do a transition to the digital meetings as we are doing today because of the pandemic. And these meetings regular, where people meet face to face and they share the different resources they have and the different challenges they face in the health sector and in the social sector. I think these meetings were really what was the most relevant about the movement here. Next slide. So these are our early lessons. First, look at the resources you already have in the health system and in local communities. Probably you already have some kind of link worker, as we have the social workers based in primary health care, and we saw community health workers in, for example, in India. Perhaps some awareness, service reform, and in-job training can activate your future social prescribing link workers. And I think it's really essential to get support from local GPs and health authorities to raise the social determinants of health and health inequalities agenda. I think it was very useful to have some GP really passionate about this. And I think setting the social prescribing service as well inside the GP practice facilitates the trust and communication with the primary healthcare team. So they are part of the healthcare team, but go out and find, engage and support the third sector, the local government and local agencies outside the healthcare umbrella. I think local government can be a major facilitator bridging primary healthcare and voluntary community sector. And in Portugal, they have the money to invest. Think being social prescribing grows better locally. I think it always starts with the local projects, but needs national commitment to thrive in our communities. And as a recommendation, find a well-known university committed to research, to monitor, evaluate, and support the growing pains. So I'm aware of the time. Maybe you don't have time for this slide. If you have, we go forward. It's fine? Okay. So about ongoing challenges. We feel in Portugal that there is political interest, many people visiting us and supporting social prescribing, but there is no money attached, and that's a problem to actually start a big movement, a national movement. The pilot project runs with the same human and financial resources as before. There is a shortage of social workers, that means link workers based in primary health care, and social prescribing can add extra pressure on already deprived service. Social workers still look at social prescribing with a little bit of suspicion. They don't really know what is the difference to their actual job, but we believe that social prescribing link workers can be, our social workers can be great social prescribing link workers, but we need to understand what are their training needs. Somehow primary healthcare is exhausted with the pandemic, low motivation for extra work, no time for projects, and in Portugal at least, the non-medical needs, the social determinants of health, they are not perceived as a priority in the healthcare and GP agenda, not as in the UK as I see. The voluntary community services provide services to primary care through social prescribing, but there is no direct financial support. So we help them to get some grants, but the money is not following the patient. Without a financial model to support the complex social prescribing ecosystem, I think it's difficult to recruit and retain the third sector. Patients are not globally aware of social prescribing and its benefits, and most prefer the quick fix. And we have to work a lot with patients so they understand this. So I think we can go to the last slide. And this is you will see a map of Portugal with different pins, and basically the red pins is everywhere where we have been presenting social prescribing to different authorities, healthcare teams, and social prescribing is only happening in Lisbon so far, but Braga in the north of Portugal is making huge steps to start social prescribing in practice. So this is how is it going in Portugal? Really local, but very passionate. Thank you so much.
Thank you very much, Cristiano. Certainly lots of passion there and lots to build on. And I think you all know how busy clinical work can be quite often. And I know Cristiano has done quite a lot to be here with us. So we're really grateful. What was interesting listening to you, Cristiano, is how you described this as a grassroots movement, which it is, and how it started in Portugal. And I loved how you just brushed over the numbers. So we had one patient, then 30,000, and then the president got involved, and then the mayor as well. And then in your heart, the best thing of all, which is what we love most of all as well, is to meet the people on the ground, the communities, the link workers, the social workers, the municipality leaders, everyone delivering the activities from the voluntary care sector, and those meetings keep us alive, and they show us what social prescribing really is about. So I absolutely enjoy that, and we got the message very clear there. So thank you so much, Cristiano, or shall I say obrigado. Cristiano.
Obrigado.
Perfect. Obrigado. Thank you. We're now going to move on to Finland. So Mia, tell us about your fantastic work. Tell us about social prescribing in Finland.
Thanks, Bogdan. It's so great to be here with you all. Can I get the next slide, please? I have to start with the environment of social services and health in Finland. We are in the middle of a big reform. There have been new regional health and welfare counties that have been founded just last year, and they form a new public administrative level between government and municipalities, and they are going to be responsible of the healthcare and social services from the next January on. So we are in the middle of a really big reform at the moment. At the moment, and for the past 50 years, the municipalities, there are more than 300 municipalities in Finland. The municipalities have been responsible for the services, but now the services are shifting to these new counties. The counties they will be self-governing, and we just had our first county election. And the new county councils, they have had their first meetings last week in every 22 new counties. So we are really excited at the moment, and a big change is going on. And what comes to health promotion, we see social prescribing as part of health promotion. And there will be this new integration interface between these new counties and municipalities, and they have to find out how to do it together. And it's by the law, it's the responsibility of both municipalities and the county to promote the health of the citizens. And there is also quite a lot of money for developing services available at the moment, and that's something we also have advantage of. Also applying social prescribing. Hamad, could I get the next slide, please? So I come from Lapland, and it's quite opposite to Singapore because we have we are the northernmost part of Finland, and we have 2 person per square kilometer in our area. And also our communities are quite small. One bigger city of 60,000 citizens, but the rest of the municipalities are about 1,000 to 7,000 citizens. So we are the first in Finland, in Lapland, to implement social prescribing that includes a link worker. And we got support from the Ministry of Social Affairs and Health to pilot social prescribing in Finland. And we developed this rural model because we have had to implement it into our environment and our system. But we have all the same elements than everybody else around the world. So identifying the needs and making the referrals, and they are with our health and social care professionals and also employment services. The link worker role in our small communities, it's the municipalities responsible, and we think in this coming change that it could be also staying with the municipalities instead of shifting to the counties. But that's something we have to figure out in the future in the national level, I think. The community support and development is by the public side, it's in the municipalities' responsibility in Finland. But of course, especially in these small communities, you have to gather and get everybody on board, and you have to integrate everything to make the asset to where you can send the people, the patients. The funding comes from several sources, and I think that's the case in most countries, and so it's also in Finland. Next slide, please. Thank you. And where are we going now? We definitely have to continue developing and implementing social prescribing and get more people and more stakeholders on board. Then we need some kind of backbone organization for social prescribing in Lapland and also in Finland. And I can't emphasize enough this network collaboration and shared leadership in every level, in this municipality, community level, in national level, in international level. It's very important, I think, and you won't succeed if we don't develop that one. And then we have to test different models in different cities and find out what would be the model in Finland, in our system, in a bigger city. Now we have this rural model, and I'm not sure even if we can take it to another part of Finland, or do we have to like build it from the bottom up, even in our own country. But definitely, I think we need to test more different kind of models and like let every flower flourish, and then learn from that. Learn from the best practices. And then one point that's missing from the slide is that we have to enhance our data collection for the research, but also for developing the service in the community level and national level. That's something we really have. And one thing that's helping us is that our Ministry of Social Affairs and Health is awake and is investing 25 million euros coming 3 years to implement low threshold well-being services that is almost equal to social prescribing. And we are now going to start a national network with our Institute of Health and Welfare, and there is some support from the ministry side, and we have this like goal that by year 2024, in every county's area, there should be this kind of low threshold well-being services model, including social prescribing. So we are lots is happening in Finland, and there is a lot of interest and curiosity about the social prescribing, what it's about. And one more thing I have to say, we are in the beginning of a path, and we are getting a tremendous amount of support and help from our international network and friends here, and we are so grateful about that and really depend on that. So thank you.
Thank you so much, Mia, and please join me in saying a big kiitos to Mia. I think we're learning some Finnish as well today. And thank you, Mia. I think it's fair to say for anyone visiting Lapland for Santa Claus, just visit Mia and learn about social prescribing at the same time. It would be a two-in-one experience as well. Now, moving on to Australia, and our lovely colleague from Australia, Sean, will tell you more about the model of social prescribing there.
Hi, well, I thought, Bogdan, you were going to say good day, Australia there, so I might just say good day to all my colleagues who are dialing in Australia on a Friday night, no less, everybody. Now, how dedicated is that to the movement? So if we can pop on to the next slide, thanks, Hamad. So as I start my presentation, I'd like to acknowledge the traditional owners of the land from which I'm presenting today, so that's the Boonwurrung people. And I'd like to acknowledge their elders past, present and emerging. And as I talk about the next slide, I can just show you the geography of Australia. Many of you may have been here, some of you live here. I'm based down in Melbourne, the red dot at the bottom. I think Lexi's on the call too, who's also down there. And we've got social prescribing happening across the country. Now, different to the UK, it's not a national model. It's a model that has built up, and I'll show you how it's sort of evolving. But similar to what I think you're experiencing on this call, it's a highly connected community. And I think the richness of what is happening in social prescribing is that the connectors connect, and that really sort of encourages the community, and sort of it's that word of mouth getting things going as we build infrastructure. So if I can pop onto the next slide. I wanted to talk about, this is not a complete list of all the stakeholders, but in terms of what you've heard from others in terms of the timelines, you'll have heard 2019 mentioned, 2020, 2021, and really thanks to the Consumer Health Forum, Royal Australian College of GPs and Health System Sustainability at Macquarie University, they kicked off really the sort of putting this on the map in Australia together with other partners like IPC Health, Inala, Primary Care, Mental Health Australia, UQ, really just to sort of frame out what this looks like. Had a round table, put together sort of the paperwork and really sort of, if you like, put the charge for social prescribing through. And I think that was the impetus for many of us getting involved in what Lee said, you know, is very much you sort of axiomatic, a common sense approach, but how do we build then the evidence to think this through? Partners that I've been working with, for example, I'm at the University of Melbourne, ADMA have been really key in building up a community of practice. So we have well over 1,000 people now regularly dialing into bi-monthly calls. And through the COVID pandemic, that really has kept people connected, motivated, sharing information and really sort of making the most of what we can't do and sort of focusing on what we can do to work together. And lastly, in terms of some of the work that people have talked about is really sort of this activity from down here in the right of the neighbourhood houses and community associations. So really making sure that it's reaching across the whole of the organisation, the country. Now, there are many other players within this, but I just sort of wanted to call out a few. Now, if I pop on to the next slide. Now, many of those players and others have really been contributing to the developing policy platforms. I think this is really key. So here is the Social Prescribing Roundtable on the left-hand side in 2019. Like many of the other countries presenting, we've been going through long-term health reforms. There's a focus on primary care at the moment in terms of what primary care needs to look like for the future as part of a 10-year plan. And also recently launched last year a new national preventive health strategy. Now, what we have in Australia is something similar to what Kate described a little bit. So we have a system of Commonwealth, and then we have states and territories. And states and territories and Commonwealth work together with some things and sort of work separately on others. And I think the opportunity, as you've been hearing throughout this presentation, is the opportunity to bring the activities together so we don't duplicate, so we build together and we collaborate and we build consistent data sets. We understand what the outputs are, and we do that nationally and we do that internationally. So we build a very strong body of evidence to help people who access the services. And if I can pop onto my last slide. Hamad mentioned at the beginning around the social prescribing student collective. In fact, I spoke to Grace yesterday, who started this movement. This movement started probably about a year and a half ago, working with Bogdan and the team in the UK. It's based on the social prescribing champions model. Again, to the great collaboration. This really started through a few conversations and some very generous GPs. So Charlotte Hespy here is in New South Wales. Mark Morgan, who was instrumental with the RACGP with the CHF roundtable, again, very much instrumental in launching this. So again, it's sort of people bring their resources to the table and work together to build up what I call these ground up movements, to put things together. ADMA at the moment are collating all the resources, so we certainly have that. This is available and you can see that online. And also, as others have talked about, sort of the different types of social prescribing. So what we would like to do is what Kate's talked about, what Mia's talked about. So we're still in that sort of guided coalition, but our vision is really how do we bring this together to create a very robust sort of national approach. So without further ado, that's back to me. And I know we're, I think Bogdan, I kept on time there, did I?
Fantastic, Sean. That's absolutely brilliant. I'm conscious we also started a bit late, so I think what we'll have to do, Sean, we will do both questions and answering in our last part, which was really to get the audience to find out a bit more about the challenges and experiences of those starting social prescribing within their own countries. So we'll try and do a bit of a two-in-one with a Q&A. And Sean, I would like to hand over to you to lead that process if you want. I know there's some fascinating questions on the chat, but I also know you had a short question for some of the presenters as well. So by all means, we can do that. We have 10 minutes left, as I'm being told, and I think we can work with that. And for those of you that we've not had the chance to interact with, there will be plenty of time, I promise, over networking. At the end of the session, there will be a table international, so come and meet us there as well.
Yep, no, thank you. Well, look, I have got some questions, but I would like to ask some that have come up in the chat, if that's okay. So Michelle, you asked the question about the wellbeing conversation. So link workers use the wellbeing conversation. Is this conversation similar globally? It's certainly similar in Australia. It's what matters to you. But I might pick on Kate. Can you answer what happens for Canada? What's the conversation locally?
Thanks, Michelle, and thanks, Sean. It does look like asking what matters to you and focusing on the self-determination of the person, so that the person and community can co-guide that process. I should say, though, that the different models across Canada do look really different. And across our country, there has been, just as in the US, a focus by many folks on the more material social determinants of health to begin with. So making sure people have access to income supports, food, and housing. And so we're slowly still trying to push people to an even more holistic model that focuses on the empowerment and health promotion of the person.
Great, thank you, Kate. And Michelle, actually your question is something that I think probably we'll need to really pull some of that information together to start to collate so that we can provide a more holistic answer. But I'll go to Sarah's question too. I think this is a great question. So I might ask it of Cristiano in terms of models. So asking sort of, you know, social prescribing really starts to talk about the biopsychosocial model. Whereas many countries or sort of cultures might be ingrained in a biomedical model. Australia is certainly, I think, being quite biomedical and shifting, but the structural pieces are helping that shift. But Cristiano, what happens in Portugal? Is it mainly biomedical model? What's the model, the prevailing model?
I would say that most of the young GPs are training in the biopsychomedical model. So young GPs are aware of the social determinants of health and all about the holistic approach. So that's a plus. And I think the fact that the family health units, the GP practices in Portugal, are publicly funded, and the way it is financed provides us more time or more focus to reach out the community and invest in health promotion activities. So primary health care centers are publicly funded. They are not privately owned. And everyone is kind of employed with a different kind of contract, but I think somehow that helps, and definitely the bicycle model is leading the way in the way we organize our primary health care system since the 80s actually, because when the primary health centers, when the first primary health care centers opened in Portugal in the 80s after the setting up of the National Service Portugal. Social workers, psychologists were already part of the health centers, so they were next to the GPs, next to the nurses. So kind of creates the environment where social prescribing can thrive. But the problem, it wasn't well connected to the third sector. It wasn't well connected to the community, and that's where social prescribing innovates in Portugal.
Thank you very much indeed. Now, I think that, I hear that theme consistently in terms of connecting across the sectors and making sure it's the right service at the right time in terms of what's required and the right context for that person. Mia, question for you, if I may. And this has come from one of our co-presenters, so from Singapore. Now, with 2 persons per square kilometre, how do you manage loneliness?
Oh, thanks for the question. I have a counter question. How many friends do you need? Because if you have a community of 800 people, you won't be lonely. You know probably better the people there than you know your neighbors in a big city. I think loneliness is it can be an issue, of course, but I'm not sure if it depends on the density of the population. That's my experience. I come from a very small town from Lapland originally, and I never felt lonely there.
Yeah.
But I can feel lonely in big city.
Yeah. No, I think that's
but the question is good, because we have problems, challenges there, because there are not so many different kind of assets, and there are not so many different kind of groups for different kind of people. So that's something we struggle with, and we have to find solutions to bring things together and like pop up things more than long going. So we have to gather up all the assets and resources to get the groups rolling, and there are some challenges, to be honest. But yeah, thanks for the question.
No, thanks, Mia. And I'm sure we could go on with many questions, because I can see sort of through the chat, Bogdan, next time we're going to have have a little prayer to have a longer session. We'll have to ask Marie and Michael. I think some of the questions that we would like to bring back to you is sort of this notion of startup, scale up and sustainability. So perhaps in the spirit of leaving everyone wanting more, we'll be able to sort of package some information and come back to you on a future occasion. But please do pop things in the meeting chat. We will post them, we will get back to you. And with that, thanks to all the presenters, and back to you, Bogdan.
Thank you ever so much. I think you mentioned the session. We could go on for a day. Let's go for a day if we're asking for more, please. I think a whole day would be just about right for this kind of audience as well. I really hope you've enjoyed it. I think one thing is very clear, Mark, because we go to the final slide. One thing is very clear to me here. Many people, and if we poll Hamad for now, just in the interest of time, I know we need to wrap up. So if you go to the final slide of the presentation. So we've heard a lot about funding. We've heard a lot about policymakers. We've heard a lot about models and social prescribing. We've heard about agendas being thrown left, right, center. But one thing is very clear to me here. we've heard from people who are passionate about social prescribing, who would go our own ways, who would do this on top of their usual work day and day-to-day job. All the people in today are doing this as an extra. They don't do this as a full-time job. They do this as a plus because they're passionate and they see this as hope for the future of the healthcare system and countries. And that's to be commended. Social prescribing has been, is, will be a reflection of its people, just as it's been in the UK and just as it is across the world. And for that, I'm grateful for the ones presenting today. And just to say, this really is shaping up to be igniting a true global movement. And so our call to action for you is just to show you we've all started at a different place, be it with the students, be it with the workforce, be it Cristiano involving one patient and leading to 30,000, and then being passionate about involving the rest of the community, being Kate, launching CHISP just now, the Canadian Institute for Social Prescribing is going to become our best friend, of course. It all started with individuals at different points in time. So my call to action for all is, where are you starting at the moment? And how can we help? Get in touch, reach out to one of us, because each one will help one at the day. And we are looking forward to collaborating with as many of you as possible. We're populating a bit of a global database. We're going to transform it into an interactive map so that you can see people across the world easily. We're developing a community of practice, and we are grateful for the support of Michael, Marie, and NASP, all the partners involved across the world, especially our international partners who will be helping us build the library versus the knowledge exchange as well. I will stop on that note, but also invite you all to join our networking session, because there's a lot more questions that you've had in the chat that we have sadly not been able to answer. But I think, Michael, Marie, that's a call for action for a one-day conference on the global side of as well, that I hope many of you will join in the future. Thank you ever so much. Thank you to the presenters who joined at random times throughout the day. Very grateful, and have a lovely rest of the conference. Thank you, everyone.